Good morning, and thank you very much for having me today. My name is Diana Hill, and I am the Director of Home Support Services for the Greater Vancouver Community Services Society. We're just working on the presentation here, but I will sort of comment on, so much has been said, and so much of it rings true in the business that we're in and the job that I have to do at Greater Vancouver. One of the things that I find a little bit difficult about my agenda for today is that I'm so used to standing up talking about how great Greater Vancouver Community Services is and how successful we are in our performance and that kind of thing. And here's an opportunity to really get to the other end and talk about what it means to those workers and the really hard work that they have to do and perhaps how little they're recognized, which I think we're all on the same page about. The other thing I was thinking about, too, to Anita's point, is how many of us really want to do this job. This morning, I had the privilege of going to the dentist. And I was in the escalator coming up here going, dental hygienist, home support worker. You know, I'm not sure I'd want to do either one of them, but really, the home support worker truly is a job that's underpaid, undervalued, underappreciated. Somebody talked about them being the bottom rung yesterday, and I sort of believe that that's true. I don't know if they feel that. I think in some respects that they do. But in any event, we'll get going. My presentation today really is about what they feel, what they're thinking, my perceptions of why they are in home support and why they might choose to leave home support, and therein lies the problem of the turnover. So, a little bit about Greater Vancouver. We are a nonprofit society. We are dual service. We used to be multi-service. We're now dual service. Our largest program is the Home Support Department program. We also have group homes for developmentally disabled adults in and around Vancouver. There's 6 group homes there. We've been in business for 41 years. Same man at the helm for 41 years. He started the business when he was 21, mowing lawns, shoveling walkways, and taking people to appointments. We've held successive contracts with the health unit since 1978, and we are currently one of 3 contracted providers in home support contracted by Vancouver Coastal Health. At any given time, we have 2,600 clients actively on service. 53% of these clients fit in a cluster care model of service delivery. May not be as big as people had originally thought. I heard some numbers yesterday, and I was kind of like, well, really, it's a 50% goal that we have. So in those areas, you're probably looking at a little bit more continuity than clients that are receiving service in perhaps a traditional model of service delivery. We, as a contractor of the Health Authority, have performance-based funding. So we have a requirement to have a certain level or a certain percentage of clients in a cluster care model of service delivery. So we have to work very hard to keep this and achieve this in order to maximize our funding from the Health Authority. We have, and these are my stats from April, but we have 50,000 visits per month. 50% of those clients have a PAG, or a delegation of task, which involves nursing to do some training and setup of services in the client's home. We have 544 active CHWs, both casual and full-time together. We have 4 full-time LPNs and 1 full-time RN, very lean. I have a number of casuals in addition to that, but that's my full-time complement. 15 full-time supervisors, which do the scheduling. Each desk is about 5,500 hours per month. So it's a very, very busy desk. When we talk about the home support workers being out in the field independently, they get to they don't get to organize their time, but they travel freely amongst the clients as per their schedule. But if they need assistance, we may not be able to answer the phone right away when they call. Okay, so they really are independent. They're left to their own devices until such time that somebody can get back to them when they're in the home. So who are the CHWs? I don't think I'm telling anybody anything new that you haven't already heard, but they are unlicensed professionals. Predominantly landed immigrants from the Philippines, South Asia, Eastern Europe, and Africa, in our experience. Many are nurses or other healthcare professionals in their home countries. They are the eyes and ears of case managers, supervisors, and the family, in large part. We entrust them to report back. As we talked about, that being a large responsibility. They have to be the eyes and ears. They're there to report any changes in client condition. Everybody relies on them because they're on the front line and they see the changes, they see what's actually happening, and they have to question, they have to use judgment. They can't necessarily make any decisions. They're always forced to call the supervisor to help them negotiate that situation. Why they like home support. If they can get continuity, of clients in their schedule, they are able to develop a connection with clients and their families. Some of my workers have been with their clients for 10, 15, 20 years, and it's a real relationship that they develop. How do you manage the boundaries around that? Difficult. How much added resources and time do you need to spend with that worker if that client passes away and they've been an integral part of their care for so long? All of these things are important. I imagine, I don't know much about residential care, but they may not see the same clients every day or in hospital. Okay? It is feel-good work. That's kind of why I like home support too. They're kind, caring people, very kind, caring people who feel good about their contribution to their clients' well-being. We don't think we'd like to do it. These are the people that should be doing it. That's why they do it. And they really, really do care about the work that they do. They work independently in that community. I've always so touted this as a reason why they might not like working in home support. In our case, they like the additional training that we provide. And for those that are longer-term workers and have stayed with us for a period of time, and we do have a portion of our workers that have been with us for a significant length of time, it's usually the turnover that we see in the first sort of, I don't know, I'm going to guess 2 to 6 or 8 months where we see the turnover. So if we get them in and we nab them and they develop these relationships and they can see the positive side of home support, they do end up staying for a significant period of time. So therein lies the loyalty to the organization and to their clients. So here's a whole list of why they might not like home support. It's hard work. The complexity of clients has increased. It's no longer having tea or going for the walk or getting a cup of coffee. There's little, if any, companionship. There's just no time because it's busy work. Okay, they're doing more with less time and are often in a rush to complete tasks and get to the next client. Okay, this is built into the system. The health authority is looking for efficiencies, and so we're having to do more with less. I think we're all having to do more with less, but due to a lack of funding, this is the sort of scenario that's been created for the workers, and we put a lot of pressure on them to get in there, do what they have to do, and get out. We try to argue that it would be nice to say, "Hi, how are you today, Mrs. Smith? Can I get you a cup of tea while I'm doing the laundry or while I'm doing something else or before we have your meal or after we've done your personal care?" There's just simply no time to do that anymore. I talked about working independent in the community. Some people like that, some people don't. If they do like it, they are often, and I alluded to this before, but they're often without immediate supports or supervision, and that could be a downside. Scheduling, we've talked a lot about this. Large gaps in schedules where the work is heavily weighted in the mornings and then again in the evenings around supper time. Also the availability of a 10-hour window. Okay, that's a lot of time to give up where you can't schedule appointments, you can't schedule lunch with your friend, you need to be available to the agency should somebody call in sick and we need to redirect that care to a different provider or a different worker. Some would argue that they're ill-prepared for home support. There is a feeling that the schools don't necessarily fully prepare them for what it's like to work in home support independent in the community, traveling around to home after home after home. It's not the same as working in a residential facility. It is very different, and there's a lot of things that go around with that. So they get the job because they know they can probably work pretty quickly. They get in there, they find out, perhaps this isn't really what I want, and then they're likely to move on. Client expectations, there's been a lot of comments about this, usually to do with care plan tasks or promises made that can't be delivered. So we'll tell a client in the hospital that of course you can have your bath at 8 o'clock in the morning. And then we get into a situation where we need a number of people because everybody wants their bath at 8 o'clock in the morning, right? So we have to then negotiate that. Sometimes they wait for the worker to get there. And then the client's having that conversation with the worker who's very ill-prepared to have those conversations, and they shouldn't really be put in the position of having to negotiate that either. Negotiating difficult conversations with clients or family, often again to do with care plans. They want the worker to sweep the back porch. The worker's argument that we try to arm them with, well, it's not in the care plan. It's also not an authorized task, and that's what our job as a contractor to do, is provide the care that's authorized by the health unit. Okay, so we end up having to negotiate that for the workers, but sometimes they're left to negotiate that. If the client doesn't like what they say, the client doesn't want them back, they might want to go back, they don't want to get in trouble. There's all these sorts of dynamics that get in and around that when the worker's in the home. And it's uncomfortable with them, sometimes often in English, which perhaps might not be their first language. Inappropriate treatment of CHWs by clients. hope I'm not going to get in trouble for this, but there are often accusations of theft, harassment. They're treated like they're the hired help to do all the tasks in the home other than what's simply authorized and might be related to their health care. Can you please do my son's laundry? Okay. Can you lie on the bed with me? I'll give you $20. Okay. And I don't like to talk about that, but to be honest with you, my field supervisor's been out 4 times in the last 2 weeks, 4 different clients, having that kind of conversation. I'm here, the worker's perspective, I'm here to help you. I'm here to do good for you. And this is the treatment that I get back. Lack of respect. They're the lowest rung. Do they feel that because they're an unlicensed professional? I don't know. I think we'd have to talk to more of the workers, and perhaps my union partners up here would have a better answer to that, but I don't doubt it. However, why they get into home support when they perhaps first arrive in Canada, or because they first decide that this is a job that they want to do, is that they know there's fairly imminent employment following graduation from school. It's a 6 to 9 month program. It's not overly costly. I don't need a lot of prerequisites to get into the program. They can likely be hired in home support quicker than into a residential facility. Might be a little facetious to think that they come to us so they can work while they're waiting to get into a residential facility placement, because that's the desired place to go, because that's where I'm going to make more money. They think they know what home support is, and again, the schools may not have sort of identified what it really is and what it truly means to work in home support. They like the idea of working independently in the community, and they may not be able to work in their trained for capacity in their home country. So this is the option that they have available to them. And why they get out of home support. I think I alluded to this before. Their application to residential facility has been accepted, and I'm going to move on to get more pay, to have a regular schedule, and work in a team environment. They don't have regular hours. They don't have enough hours, potentially. They're judged by clients unfairly at times, and they're just tired of the complexity and the ever-changing nature of home support. I don't think I'm saying anything that other people haven't already said or understand. So how GVCS tries to help, just throw it out there. We really do make every effort to take the time to be with the workers and to listen to them when they're in the office. They don't come in very often, so when they do, to get their supplies, we take the time to talk to them, try to prepare my supervisors to work ahead on their scheduling so they can offer that time when they're in the office and try to make that connection. Often talking to them about the importance of their contribution to the agency and the success of the organization, and also the quality of care to the clients. We are currently participating in 2 pilots, the 8.5-hour window pilot, which for us has been very successful. We've probably had 55% participation of the people that we asked to participate in it. And in one case, actually, the doctor has said to the worker, keep doing what you're doing. You're in better condition than you were before when you were working a 10-hour window. We are currently also piloting an overnight program where the workers have fixed shifts. So they work from 10 in the morning or 10 at night till 8 in the morning, and predominantly turning clients, getting them to offload on wounds and that kind of thing. And the workers are loving it. So the pilot's been extended for 3 months, and we'll see where it goes from there. October 18th is Seniors Care Worker Day. We often have celebrations for that. And last year we did we combined it with our employee recognition event for years of service on the same day, and actually held that together. Employee engagement surveys, not something that we've typically done in the past. We are working towards becoming accredited with CARF Canada, and it's a requirement to do an employee engagement survey. Part of our contract with the Health Authority, and we don't have a part in this, but the Health Authority conducts surveys from clinicians and from clients that regularly work with us to sort of determine our performance levels and that kind of thing. And so in turn, we do that with our employees to sort of see if we can get our finger on the pulse about what's going on. Also very successful. Training is a big part of the programs that we offer to our workers. They love the training when they come in it. They're always hungry for more. We have compulsory trainings, and we have in-service trainings that are voluntary. And so through that, they get additional supports and supervision. Just some of the things that we do to try and help and let the workers know that we care about them and that the job that they are doing is important regardless of all of these other factors. So I don't think I'm telling you anything new when I say that we have a problem. There's a need for CHWs that can't be filled or can't be filled for the long term. There's a need to provide home support services to more and more clients who require more complexity of care. It's an important job that does not get the recognition as it deserves, not only in terms of increased wages and benefits, but also the status or the profile due to being unlicensed and that kind of thing. And for an organization, here to tell you, there's very tight margins. There's not enough money to cover the costs to provide a home support program. So I think that's sort of what everybody's here to sort of talk about and think about and move forward with. And this conference has given me sort of lots of information and lots of thoughts and perspectives to take away. So I thank everybody for that, and thank you for your attendance.